Hello, everyone. Thank you so much for joining us today to learn more about cervical cancer. Our speakers today include Dr. Helen Kelly from the Department of HIV, Hepatitis, and STIs at WHO, and Dr. Michelle Chevalier from the U.S. Department of State, where she directs PEPFAR. Please put any questions you have for our speakers in the Q&A or chat, and they will be able to answer your questions at the end of the session. Additionally, the session will be recorded and uploaded onto our AVAC website with PDF copies of our speaker slides. And with this, I turn things over to our first speaker, Dr. Helen Kelly, and please find her bio in the chat. So Helen, over to you.
Thank you so much, Alison, and hello, everybody. First of all, I'd like to say thank you to Alison, Jason, and colleagues at AVAC for giving us the opportunity to speak on cervical cancer prevention and control. I'm presenting this in collaboration with my colleagues Shona and Maribel at WHO, who should be on the call today, and hopefully we'll also get an opportunity to hear from them in the Q&A session later. So as an overview of this talk, I'm going to talk about the epidemiology of cervical cancer and HPV infection, and include the current control or tools that we have available for cervical cancer control. But to begin with, I'd like to talk about the epidemiology of cervical cancer. And many of you are probably familiar with this map showing the incidence of cervical cancer, with the highest incidence in the dark red. So we can see that there are quite large disparities in incidence of cervical cancer according to geographic region. In 2020, there were over 600,000 incident cases of cervical cancer with a high mortality rate. And the majority of these incident cases and deaths occurred in low middle income settings. And this is largely a consequence of three factors: the access to the HPV vaccine, screening and treatment tools, but also the impact of HIV in settings where incidence of cervical cancer is high. Despite this, cervical cancer is one of the most preventable and treatable forms of cancer in women, but only provided that it's detected early and managed effectively. And because we have these tools available to prevent cervical cancer, in 2018, the WHO announced a call to eliminate cervical cancer as a public health problem. And what this means is that cervical cancer could be reduced to less than 4 cases per 100,000 women. And in order to achieve that target, we have this threefold set of targets, in that 90% of girls are fully vaccinated with a HPV vaccine by the age of 15 years of age, that 70% of women are screened with the high-performance screening tests at least twice at the ages of 35 and 45 years of age, and that 90% of women who have precancerous lesions identified during screening are treated appropriately. So just to give some overview on the natural history of cervical cancer and HPV, then we know that HPV is necessary for cervical cancer to develop. HPV itself is a double-stranded DNA virus with a spherical shell or capsid composed of 2 proteins we call the L1 and L2. These are important proteins because the currently available HPV vaccines are designed on these proteins. There are also what we call oncoproteins, the E proteins that are switched on when HPV persists and develops into cervical precancer. There are over 100 HPV genotypes identified that infect the skin and the mucosal areas. 40 of these genotypes specifically infect the genital area of both women and men. 15 of these are considered high risk or oncogenic types in that they cause cancers in these areas. 2 of these types, HPV 16 and 18, are linked to 70% of invasive cervical cancer, whilst an additional 5 types, so altogether 7 types, are linked to over 90% of invasive cervical cancer. And the reason I picked these out is that these are what the current HPV vaccines target, and we'll talk about them a little bit later. In addition, we have these low-risk type 6 and 11, and they're linked to anogenital warts. HPV is the most common sexually transmitted infection, and between 50 and 80% of sexually active women will acquire at least one HPV genotype in their lifetime. However, most of these infections will clear, and the median duration of clearance is approximately 8 months, but can be up to 2 years. And while new infections decrease with age due to changes in sexual behavior, the risk of persistence increases with age, and the persistence of high-risk HPV infection increases a woman's risk of developing precancerous lesions and cancer. So when we look at the pathway then from HPV infection to cancer, we can break it down into these various stages. A woman can acquire HPV infection, we see in the green box. As mentioned, most of these infections will clear, but some of these infections will persist. And if left undetected through screening, these infections can develop into what we call high-grade squamous intraepithelial lesions or cervical precancer. And again, if these lesions are not detected on screening or treated, this can develop into invasive cancer. When we look at the risk profiles by age, then we can see in this green line that the risk of acquiring HPV increases quite dramatically at the point of sexual debut. So from in the teens and up to the age of 20, we see this quite stark increase in the HPV prevalence in these populations because HPV is quite easily acquired upon sexual debut. But over time, these infections will clear, and we see this risk decline in older age groups. The risk of cervical precancer or high-grade SIL then increases between the ages of in the 30s and the 40s, and this explains why we have a screening in these age groups. And then cervical cancer increases in the older age groups, with the median age of diagnosis at the age of 53. So one thing I wanted to highlight here was the importance of understanding the age of sexual debut and the role of HPV vaccination in targeting those individuals prior to exposure to HPV. So across the pathway from HPV to cervical cancer, we have various tools to control HPV infection and cervical precancer development. So to prevent HPV infection in the first instance, we have a highly effective HPV vaccine, and it's most effective when administered prior to exposure, so that's prior to sexual debut. And this is why we have guidelines for administering HPV vaccination in young populations aged 9 to 13 years of age. In terms of screening, then we have different tools for screening, including tests that target the HPV DNA, and then traditional screening modalities up to now or prior to the wide-scale introduction of HPV DNA has been the cervical cytology or the pap smear, mainly used in high-income settings, but also visual inspection using acetic acid or Lugol's iodine, which may be used more commonly in lower resource settings. In terms of treatment modalities, we have effective treatments, including ablative and excisional methods, which can be used once women have been identified with cervical precancer. And then for treatment of cancer, we have, as for other cancers, surgical, radio, and chemotherapy. So just to go into detail then on the HPV vaccines, we have currently 4 available vaccines. 2 of these vaccines target 2 types, high-risk types 16 and 18. We call these the bivalent vaccines. There's 1 quadrivalent vaccine, which in addition to HPV 16 and 18 also targets 6 and 11, which cause the anogenital warts. And then the more recently available 9-valent vaccine targets up to those 7 high-risk types I mentioned earlier that contribute to over 90% of cervical cancers, as well as the low-risk types 6 and 11. The currently available HPV vaccines prevent HPV acquisition and associated persistence of those vaccine types and precancer development associated with those precancer types. So the vaccines are prophylactic, and we do not yet have any therapeutic vaccines. Protection is type specific, so a vaccine targeting 16 and 18 will prevent infection from 16 and 18 and associated precancer associated with 16 and 18. Although there is some evidence of cross-protection associated with these vaccines. So initially, the vaccines were administered in 3 doses, and this graphic is just showing that in comparison to antibody response, which would be here on the y-axis, the antibody response following vaccination peaks after the 3rd dose, but still is retained at a high concentration with 2 and 1 dose, and then maintains a high antibody response over time. And we have evidence now of sustained antibody response up to 14 years after vaccination. So what about the effectiveness of the HPV vaccines then? So the first outcome to look at is the prevention of HPV infection. And this was a large review looking at population level data in countries that introduced HPV vaccination in school-aged girls. And in these 14 high-income countries, these studies looked at HPV prevalence before vaccination and again after vaccination in different periods of time. And what this graphic is showing that in the largely vaccinated population, so that would be girls aged 13 to 19 years and women aged 20 to 24 years, we see this decrease in HPV prevalence in the post-vaccination period compared to the pre-vaccination period, with a risk ratio of 0.30 for the girls largely vaccinated, and a slightly lower risk ratio for the group of women, the majority of whom may have been vaccinated, but not all. And then sort of as a control group, we can see in the older aged women who would not have been vaccinated, they would not have been eligible to receive vaccination at that time. We don't see this decrease. So this evidence is suggestive that the HPV vaccine is effective against HPV infection. But ultimately, we'd like to know about the effectiveness against the ultimate endpoint of invasive cervical cancer. And this recent paper that was published in 2020 from Sweden is the first evidence we have on population level effectiveness of the HPV vaccine against cervical cancer. And this study followed 1.6 million girls and women aged between 10 and 30 over an 11-year period. And they compared the incidence of cervical cancer in those girls and women who had been vaccinated compared to those who did not receive the vaccination. And what they found is that there was an 88% reduction in cervical cancer incidence among those women vaccinated at the younger age group, less than 17 years. The majority of whom would have been vaccinated prior to exposure to HPV infection. So this is evidence of high effectiveness of the HPV vaccine against ultimately the endpoint of cervical cancer. So what about the coverage of the HPV vaccine and availability of vaccine worldwide? Well, this follows a similar pattern to the first map that we'd seen about the disparity in access to or in disparity in incidence of cervical cancer. We can see that largely the countries are increasingly introducing HPV vaccine, but we do see this slight a higher probability of vaccine programs in high-income countries compared to low-middle-income countries. However, to date, 134 countries have introduced HPV vaccine in their national program. So this is very encouraging. When we look at the proportion of girls then in the target age group for vaccination, that's girls aged 9 to 14 who have received the full course of vaccine, we can see that this graph on the right-hand side is showing the increase in the proportion of girls that's in the pink bars who have received the full course of vaccine, stratified by high-income countries on the top and low-income countries on the bottom. And we can see that by 2019, 88% of girls in that age group have received the full course of vaccination in the high-income countries, with a lower proportion in the low middle income countries at 40%. However, this is increasing over time, and hopefully we'll see this continue to rise. Almost 1/3 of programs were gender neutral in that both boys and girls received the vaccine. However, gender neutral programs were more likely to be available in high income countries compared to low income countries. So how do we increase coverage of HPV vaccination? Well, up to now, multi-dose schedules, the 2 and 3 dose schedules have been expensive and complex to deliver, especially in low middle income settings. And a single dose HPV vaccine could reduce costs of vaccine supply and delivery, increase access, and increase sustainability of the programme. And we have had for some years increasing data from observational studies suggesting that a single dose could be sufficient to generate sufficient antibody response and prevent HPV infection and associated precancer. And more recently, we've had the gold standard study, which is a randomized control trial that has evaluated a single dose vaccine against a control group, which was no vaccine. And this study evaluated a single dose of the nonavalent in one arm, a single dose of the bivalent in a second arm, and then the control group of individuals who did not receive vaccine. And what this study has shown is that, very encouragingly, the efficacy of the single dose of both the nonavalent and bivalent was extremely high at 99%, 98% against infection from HPV 16 or 18. And they also show that the antibody response is sustainably high up to 3 years of time. And then similarly, we see a very high vaccine efficacy against those additional types that are contained within the nonavalent vaccine. So this is very encouraging data. And because of this, in 2022, the WHO updated its recommendations on HPV vaccination schedules to allow for the option, as well as the 2-dose schedule, to also allow for a single dose schedule for 9 to 20-year-olds. So moving on to screening then, I would like to start just by commenting on the diagnostic accuracy of the different screening modalities that we have. And as mentioned in an earlier slide, we have these 3 main tools: visual inspection, cervical cytology, and HPV DNA. And what this slide is showing that is in the general population of women, we see HPV DNA by far has the best combination of sensitivity and specificity to detect cervical precancer compared to visual inspection and cervical cytology. An additional benefit of HPV DNA is that it allows for self-collection, and the PCR-based HPV DNA tests have similar accuracy in the self-collected sample as the clinician collected. And this is promising for its potential to increase coverage of screening and access to screening in rural areas and low middle income settings. And in 2021, the WHO updated its guidelines on screening so that for the general population of women, HPV DNA was recommended as a primary screening test, starting at the age of 30 years of age, with an interval of screening recommended for every 5 to 10 years. For women living with HIV, this will be, I will go into detail on this in a separate webinar, but I just wanted to mention that for women living with HIV, WHO has recommended that also HPV DNA is used as a primary screening test. But because of the very high HPV prevalence in women living with HIV, a triage test is recommended to identify those HPV positive women who are at highest risk of cervical precancer. And because of the younger age of development of cervical precancer and cancer, initiation of screening is recommended at a younger age and a more frequent interval adopted. So looking at then also, as we have done for HPV vaccination, the effectiveness and impact of screening programs on invasive cervical cancer incidence over time, I think the best evidence we have comes from those countries that have existing screening programs over a very long period of time. And this tends to be the countries in Northern Europe that introduced cervical cancer screening programs in the 1960s and 70s. And we can see in the top graphs here that over time there's been this decrease in cervical cancer incidence in these settings, and this is largely due to successful screening and treatment programs and high quality programs, as well as the introduction of HPV vaccination in the late 2000s. But there's also been some changes in disease risk factors over this period of time, such as the decrease in smoking. However, increasing incidence rates are noted in Eastern Europe and Sub-Saharan Africa, where cancer registries are available. And this is thought to be due to the shorter duration and quality of screening programs, but also the potential lack or the fairly new HPV vaccination programs, but also the very important impact of HIV in some of these settings. In terms of cervical cancer coverage then worldwide, we see here in the dark red are the regions with the lowest reported cervical cancer screening ever in a lifetime, compared to those in the lighter blue. Dark blue is the proportion of countries with a high proportion of women reporting ever receiving a cervical cancer screening event in their lifetime. So we can see here the proportions are given here in 88% compared to 15%. And also in those settings where in high income settings where screening is available, they're more likely to use either cytology or HPV DNA test, whereas visual inspection is most likely to be used in low middle income settings. So just to complete, to finish up, I just wanted to mention some of the documents, toolkits and guidance that the WHO has available for introducing some of these tools on vaccination and screening. This is not exhaustive, but there are a list of documents available that can be shared with you. And just to finish and mention some of the work that the WHO is doing on supporting countries on introducing HPV vaccination, screening and treatment programs and an adoption of guidelines that are available to reduce cervical cancer incidence and mortality across the 3 pillars in prevention, screening and treatment, but also to strengthen facility-based monitoring and cervical cancer screening and treatment but also HPV vaccination to monitor achievement of cervical cancer incidence reduction. An important area that WHO is involved in is further strengthening links with the community. And finally, monitoring the evidence, the research evidence, and also knowledge gaps through the use of living guidelines. So being aware of new technologies and also new developments through implementation science. So with that, I'll finish and take some questions, I guess, at the end of the session. So thank you very much for your time.
Thank you so much, Dr. Kelly. And a reminder to everyone on this webinar, you can place questions in the Q&A or in the chat, and we will review them at the end of the session. And with this, I now turn the present over to Dr. Michelle Chevalier, and you can see her bio in the chat. Thank you.
So, sorry, we'll go back. So good morning, everyone. My name is Commander Dr. Michelle Chevalier, and I serve in the Bureau of Global Health Security and Diplomacy in the Department of State, Washington, D.C., as the Senior Advisor for Women's Health in support of the President's Emergency Plan for AIDS Relief, or PEPFAR program. I'm really grateful for the opportunity today to provide a brief overview of the work that PEPFAR has been doing to support cervical cancer screening and pre-cancer lesion treatment in women living with HIV through the Go Further public-private partnership. So cervical cancer is an important public health problem worldwide. Globally, the countries with the highest HIV prevalence in women also have the highest incidence of cervical cancer. 2020 global data shows that the large majority of countries in sub-Saharan Africa and segments of South America have age-standardized incidence rates above 16.7. There is an overlapping presence of cervical cancer and HIV in many places where PEPFAR works, specifically in sub-Saharan Africa. It is for these reasons and more that since 2018, PEPFAR has made a concerted effort to invest in cervical cancer screening and treatment for women in these regions, particularly those who are at increased risk of cervical cancer morbidity and mortality. Globally, there are over 342,000 deaths per year from cervical cancer, 90% in lower and middle income countries. In sub-Saharan Africa, cervical cancer is one of the top causes of cancer mortality in women, where roughly 70,000 women are diagnosed with cervical cancer in 2020, and approximately 67% of women diagnosed died from the disease. As depicted in the data, in 2020, Eswatini, Malawi, Zambia, Zimbabwe, Tanzania, and Uganda ranked the highest in age-standardized mortality rates in sub-Saharan Africa, all of which are PEPFAR-supported countries where cervical cancer prevention activities are being scaled through the Go Further partnership. So beginning in FY18, PEPFAR focused its support for cervical cancer screening and treatment to countries and areas where the HIV prevalence rate and cervical cancer mortality is highest. Building on the earlier success of Pink Ribbon, Red Ribbon, the Go Further partnership was launched in May 2018, bringing together and leveraging the strengths of PEPFAR, UNAIDS, the George W. Bush Institute, Merck, and Roche, where PEPFAR serves as the implementing arm of the partnership. Go Further aims to reduce new cervical cancer in women living with HIV who carry the highest risk of cervical cancer mortality in 12 African countries. 8 countries initiated cervical cancer screening beginning in 2018. Those countries are Botswana, Eswatini, Lesotho, Malawi, Mozambique, Namibia, Zambia, and Zimbabwe. And 4 countries were added in 2020, Tanzania, Uganda, Kenya, and Ethiopia. To date, PEPFAR has budgeted over $200 million to provide over 7.4 million screens in Go Further countries. As a brief overview, cervical cancer screening within PEPFAR-supported countries is integrated into routine HIV treatment services, particularly ART service delivery sites. Cervical cancer screening modalities include visual inspection with acetic acid, or VIA, and HPV testing. Precancerous lesions can be treated with cryotherapy, thermal ablation, and LEEP. Women with suspected invasive carcinoma are referred to treatment referral sites within the same facility or established regional cancer treatment facilities within the country. PEPFAR currently does not support the treatment of advanced cervical disease, and as a result, we are highly supportive of working with partner organizations and host governments to establish these linkages as part of the comprehensive care package. Since 2018, the Go Further partnership has focused its effort on providing at least one lifetime cervical cancer screen with treatment of precancerous lesions to women living with HIV. Between the ages of 25 and 49 in areas where there is a high HIV prevalence within these Go Further countries. Since the beginning of this catalytic effort, PEPFAR has recommended a screen and treat approach as the primary approach to cervical cancer screening. However, beginning in COP22, PEPFAR programs began to transition to the screen triage treat approach to align with the WHO global strategy towards cervical cancer elimination. Additional activities for the partnership also include scientific engagement with NCI and NIH colleagues with a focus on research and implementation, information and data in order to better understand efficient cervical cancer diagnostic and treatment options. In addition, our focus has been on enhancing quality assurance activities, adverse event monitoring across the Go Further countries, which will begin in FY23. And then we are also currently in the process of assessing the capacity to leverage PEPFAR programs to enhance primary prevention services. On this slide is a brief snapshot of some of the activities that have occurred through the partnership over the last 5 years. So over the last 5 years, the partners have conducted over 10 joint technical oversight trips with 3 additional country visits scheduled for 2024. Implementation has been rapidly scaling up across the 12 countries, where PEPFAR country teams have been actively participating in virtual and in-person technical learning exchanges to refine processes and find solutions to service delivery challenges posed by public health emergencies such as COVID, pandemic that happened a couple of years ago, as well as other country-specific outbreak or humanitarian issues. Merck, in collaboration with Eswatini local partners, is wrapping up an HPV vaccine study. And Roche has been actively engaged in supporting the complete patient journey from screening to precancerous lesion treatment or advanced cancer diagnosis and treatment within through country trainings, as well as other health system support. In addition, the Bush Institute and UNAIDS have leveraged their convening and advocacy effort to host webinar workshops, as well as develop white papers and blogs to raise awareness and catalyze efforts in cervical cancer prevention, as well as develop key guidance on service integration for NCDs to support comprehensive women health services. The Go Further Partnership has conducted over 7 million cervical cancer screenings across the 12 Go Further countries, reaching over 5.5 million women to date. Of the 7.4 million screens conducted between FY18 and FY23 Q4, 382,000 or 5% of screens were positive for precancerous lesions, of which over 300,000 or 79% were treated. From FY18 to FY23, PEPFAR has invested over 168 million in secondary prevention services, and in FY24, PEPFAR is investing approximately 42 million within the COP23 plans of 12 Go Further countries to reach a total of over 200 million funds invested since 2018. Here's a snapshot of the cervical cancer cascade throughout the 5 years of the initiative by country. Just to orient everyone, the green bar represents the total number of screens conducted over the last 5 years. The red bar are the number of positive precancerous lesions identified, and the blue bar represents the number of precancerous lesion treatments performed. The gold circles is the overall precancerous lesion treatment percentage. A look at the cervical cancer cascade by country during this time period shows that the highest number of screenings occurred in Mozambique, Tanzania, Zambia, Zimbabwe, and Kenya. Countries approaching the 90% global target for treatment, and treatment we refer to precancerous lesion treatment, and this is as measured by the beginning of the partnership, are Eswatini, Ethiopia, Mozambique, and Namibia. Compared to the overall treatment statistics on the previous slide, in FY23, the program continues to experience a consistent increase in precancerous lesion treatment across the Go Further countries due to a variety of linkage and mobile health solutions that were enhanced post-pandemic, where we can see that by the end of FY23, 8 countries have a treatment rate above 80%, 4 of which are above 90%. Not included in this slide is Tanzania, whose data is still in the process of verification. However, historically, Tanzania treatment percentages have also been at or above 90% over the past few measurement periods. We still have some work to do in a few countries to optimize precancerous lesion treatment, and this is an ongoing focus for FY24 implementation activities. As the partnership looks ahead to FY25 and beyond, the primary objectives to ensure equitable access to cervical cancer screening for all women living with HIV, successful linkage of women to precancerous lesion treatment, and ensuring timely diagnosis and referral of women with advanced cancer remains the top priorities for the partnership. To add to these activities, the partners are also exploring opportunities to leverage service delivery platforms in support of enhanced demand creation, increased cervical cancer awareness and education, primary prevention scale-up, quality assurance activities, and local advanced cancer therapies. We acknowledge that this will be a global collective effort, and so we're looking forward to continued engagement with interested stakeholders on these very important issues. To highlight some of the future directions for the Go Further partnership, in October 23, PEPFAR, with the support of the Go Further partners, announced its commitment to a DREAMS OVC, which is Orphan, Vulnerable Children, and a Go Further collaboration, where we are focusing on increasing HPV vaccine uptake in girls 10 to 14 years in our catchment areas. In 2024, we will explore these opportunities to collaborate and maximize cervical cancer primary prevention for girls in our PEPFAR platforms. With a broad reach across DREAMS, OVC, and Go Further platforms, PEPFAR is really positioned to enhance uptake of the HPV vaccine by leveraging the unique strengths of each program. At full scale, this collaboration has the potential to reach over 1.6 million girls aged 10 to 14 in the 15 countries that we serve with the HPV vaccine, potentially averting approximately 40,000 to 48,000 cervical cancer cases, 31,000 to 39,000 cervical cancer deaths, and leading to an estimated 5 to 6% reduction in HIV incidence in this subpopulation. High precision testing scale-up, such as HPV testing, is also a priority of the Go Further partnership in the upcoming cycle. As some of you know, in COP 22, PEPFAR pivoted cervical cancer screening guidance to align with the 2021 WHO cervical cancer screening guidelines to support high precision testing as the primary cervical cancer screening modality in our Go Further countries where this modality is available. In FY23, 7 countries committed to conducting over 185,000 HPV screens through pilot programs with an estimated $3 million investment in COP22 funds. In FY24 or COP23, 8 countries will conduct over 280,000 HPV tests with an estimated $5 million in COP23 funding. Pilots conducted in a few of the Go Further countries before and during this pivot highlighted that although HPV testing has high acceptability, limited funding for HPV testing and sub-optimized laboratory infrastructure serve as a few of the complications to implementation and limits what we can do. Strong referral networks are needed, and external support through donors is necessary for HPV test procurement, demand generation, education, and health system strengthening. To this end, 8 of the 12 Go Further countries have placed cervical cancer prevention activities in their Global Fund grants to support these efforts. As evidenced through some of our country visits, HPV self-testing may be a game changer in alleviating some of the issues that we are seeing with access and reach for cervical cancer screening. In 2018-2019, PEPFAR conducted a few demonstration projects for HIV self-tests, and key lessons from these projects were that HPV self-collection was empowering and acceptable to women. It was quick and fast. It reduced facility workload and maximized resources. It was ideal for outreach campaigns and was impactful in leveraging existing infrastructure and the skill sets of lower level practitioners and providers. We are currently thinking through how we can utilize and support HPV self-testing as part of this pivot to high precision testing, and the best ways to engage stakeholders and governments in developing service delivery models that are sustainable over time. Last, as part of our effort to ensure quality assured services, PEPFAR will launch an electronic notifiable adverse events reporting system next week for country partners. The goal is to implement a standardized system for country teams to report adverse events related to PEPFAR cervical cancer programming so that we can improve patient safety, quality of care, monitoring, and evaluation efforts. Consistent review of the reports will also help us to distill lessons learned and improve future programming. So as we continue to have this conversation and consider an approach to scaling global cervical cancer screening, I wanted to take a moment to reflect on some key enablers for PEPFAR HIV sustained response that I think have really helped support our robust cervical cancer program to date. These sustainability enablers include public health surveillance and monitoring, quality management, local capacity and management, investments in human resources, reliable supply chain systems, maximizing our efficiencies across programs, donor resource alignment, strengthening program finance management, and then innovative financing strategies. As we continue as a global community to think through service integration for cervical cancer prevention services, thinking through and making investments into these system enablers will be crucial to sustaining programmatic gains. So in closing, looking at the data and evolution of cervical cancer screening programs in sub-Saharan Africa, partnerships such as Go Further are proving to be essential in providing a multifaceted response that can help programs to keep pace with global goals and scale up new technologies and innovations in a comprehensive and sustainable way. Some key considerations for scaling and sustaining cervical cancer screening impact are very similar to the questions that PEPFAR is currently exploring with the countries that have reached epidemic control. Namely, how do we develop a shared approach between government, multilateral partners, and community to sustain programmatic gains? How do we create enabling policy and programmatic environments that are responsive to data? What is the best way to sustain functional, technical, and managerial capacity to maintain key services, systems, and resources stewarded by local institutions? How can local governments and partners work together to financially sustain essential services and prepare country programs to meet emerging needs? What is the best way to ensure that service delivery is integrated into broader public health systems for person-centered care? And how do we continue to strengthen and sustain quality assurance programs to effectively manage and monitor quality of services and ensure positive health outcomes? So this is the end of my presentation for today. Thank you so much for your attention, and I really look forward to the continued discussion.
Thank you so much, Dr. Chevalier, for that presentation. And with this, we now enter into our Q&A with our panelists, our speakers today. And just a reminder that you can place questions in the Q&A or in the chat, and our speakers are more than happy to dive into a rich discussion. And with this, our first question in the Q&A is, if most people clear their HPV infections, why is the vaccine not recommended for older women who could become reinfected after clearing earlier infections?
Shall I take that, Alison?
Yes.
So yeah, good question. Thanks for that. So it's older women can receive the vaccination. There are recommendations for older age groups. It's just that the primary target population is young individuals, girls aged 9 to 14 years of age. And that's really because they're considered a primary target group, because the vaccine is most effective prior to exposure to that agent. So that's prior to sexual debut. The vaccines have been evaluated in older women. There are difficulties in terms of study design that maybe are a bit complex to go into at the moment, but vaccine efficacy is much lower in older populations because of their prior exposure to HPV type. So despite the fact that an adult woman may have been infected with HPV-16, for example, previously, the HPV vaccine could protect against acquisition of a new infection, but it is quite difficult to distinguish between new infections and previous infections, and the study designs can be quite complex. But certainly, it's possible for older individuals to be protected through HPV vaccination. But in terms of HPV programs, the primary target age group is younger age groups prior to sexual debut.
And then, Michelle, to this extent, are there any plans for PEPFAR to one day expand their HPV vaccination program to include these older adults? What are your thoughts on that?
Yes, great. Thanks so much for the question. So right now, PEPFAR is very much aims to align with the global guidance with regard to HPV vaccination, as well as cervical cancer screening prevention. So as we move forward and there are, a release of new evidence, we definitely make sure that we make those pivots in order to make sure that we are in alignment with global elimination efforts. So it's all possible.
And so what happens to those who didn't receive the whole HPV vaccination series?
So I guess this question is linked to the data we now have around the efficacy of the single dose vaccination. And this recent data is showing now that the single dose vaccination is effective against acquisition of HPV infection and maintains antibody concentration or durability of protection up to 3 years. So despite the fact that older cohorts of girls who may have received a two or three dose schedule, despite the fact that they may have missed the second or third dose, we now have evidence that the single dose is effective. So if they've received that first dose, they should have the same level of protection as if they've received the second and the third dose. I hope that answers that question.
And then also to that extent, Helen, would it be possible to discuss more about the impact of the HPV vaccine among those who are immunocompromised and what that looks like?
Sure. I think I know that there's a webinar dedicated to people living with HIV on the 1st of February, and I hope to go into a little bit more detail on that. I think to start off, WHO does have recommendations on vaccination of people living with HIV, and the recommended dosage is 3 and at minimum 2. And that's really just because we don't have evidence, we don't have longitudinal studies in evaluating vaccine efficacy in people living with HIV. And long-term outcomes not yet been evaluated. These studies are, I understand, being initiated. There are some studies looking at this, and we are aware that there are cohorts of people living with HIV who have received the vaccination. So it would be of interest to monitor and follow clinical outcomes over time to look at the durability of the vaccine response and the efficacy against clinical outcomes. I think this, in terms of the sort of the science or the natural history behind that, there's certainly, despite the fact that adult women may have been exposed to HPV infection in the past prior to vaccination, there's certainly some benefit from the multivalent HPV vaccines, specifically the nonavalent vaccine, which protects against up to 7 high-risk types. And that's because the probability of adult women being infected with all 7 high-risk types is very low, if non-existent. So there is some benefit to being protected from any one of those 7 HPV types. And that would protect her against cervical precancer linked to one of those types, if not more.
And then, Michelle, I know that you mentioned self-swab and possibly implementing this into some of the programs and countries. And so could you give us a little bit of more information about self-swab and what it is and some of the advantages or disadvantages to this process?
Yeah, thanks so much for the question. So yes, when we were out on our technical visits over the past year and a half, one of the things that we had noticed is that there are significant challenges with women accessing facilities, particularly in remote areas of some of our sub-Saharan African countries, in order to get screening for cervical cancer. And so what we saw with the COVID pandemic really is that we had to take the services to the women as part of the way in which we can deliver care, particularly as countries are starting to phase in MMD, which is multi-month drug dispensation for HIV. It means that they're not really coming to the clinics and to the facilities as frequently as they normally would because they're receiving their HIV medications in a 3-month block or a 6-month block for a 3-month or 6-month block of time. And so HPV self collection really has been helpful in enabling us to be able to screen women when they are receiving their services. And if they're unable to access services through the facility, it's something that can be done in their homes. It can be done at the point of care in the community in order to allow them to be screened for cervical cancer. And so, one of the things that we, really needs a scale up for is having community health workers who are on the ground who really can be able to educate women on how to perform a self-test. Self-test is also available for women visiting the facilities as well, particularly if there are, challenges with modesty or if they don't really feel comfortable being screened by a practitioner. It's something that can be done on site, but really, we're really investigating ways in which we can educate and capacitate health workers to be able to teach women how to perform the self-test on their own. And what it is, a self-test basically is where you have the swab that is utilized for testing for HPV, and the women have the ability to self-administer that swab, to take a sample on their own and then provide that sample to the provider or to the worker who's collecting that sample in order for them to get tested and screened for HPV. So I think, as we continue to move forward, there will be opportunities for us to really explore how we can scale up this method in a way in particularly hard to reach areas in order to ensure that women at least are getting their one lifetime screen as part of this effort. It has been deemed very successful so far in our demonstration projects, and I think women have really felt felt like they have control and power over their bodies in order to collect these samples. And so I think it's a great alternative, and it's very highly acceptable across countries. And so what we're really looking forward to at this point is figuring out ways in which we can help to sponsor the procurement of these supplies, which are on the little higher side as compared to VIA screening and within the facility. But I think, if we can find out the financing strategies and discover partners who can help assist with this, it will definitely help with the effort.
And then we have another question on, is there a possibility of the cancer resurfacing after clearing earlier infections? And then another shout out of great presentations.
Is that directed to me, Alison, or should I take that?
Yeah, I think you can take it.
Okay, interesting question, Rachel. Certainly the definition of clearance is not always that easy to determine. A woman could potentially acquire a new HPV-16 after clearing an old HPV-16. So there's sometimes difficulty in attributing the later cancer to the 16 that's been more recently acquired to that that's been previously acquired. So HPV is quite a tricky virus to define fully. There's some latent periods or latency involved also that's not been truly elucidated. It will depend on the time period between clearance and the cancer diagnosis, I guess. If there's been a long period of time between clearance and cancer, it's unlikely. However, women who undergo frequent screening and are repeatedly HPV negative in successive screening events have the lowest risk of cancer in the future. But equally, a HPV infection detected in screening is not indicative of cancer, and there's many other tests beyond HPV detection that are used to fully diagnose if a woman has cervical precancer or cancer. So there's many steps in between the HPV infection and cancer development. And within those many steps, there's various interventions that can be deployed to prevent the cancer in development. So I'm not sure if I've fully answered your question, but yeah, maybe you can write something in the chat if not.
Thank you. And I just want to note that Maribel has put into, I think, the host and panelist chat, how WHO recommends using HPV testing on provider-collected or self-collected samples and recommends that self-sampling is available at health services. And there is an additional link that I will put in the chat as well with more information. We also have another comment that says the self-testing HPV kit is interesting, and it is the first time that some of our attendees are hearing about this. The greatest scare normally is the healthcare screening process is quite uncomfortable. And so, Michelle, I'm not sure if you have any thought on that or follow up.
No, I think that the comment in the chat is very well, really captures a lot of the issues that we've had to address in our cervical cancer screening program. I really appreciate the self-test, because what when we visited one of our sites, what happens is that the provider would educate the patients on HPV testing, and then would do a demonstration for the patient so that they understand how to collect the sample, and then step out and allow the woman to collect the sample on her own. And so it really shows that great collaboration between provider and patient in order to have a health experience that really caters to their specific needs. So I think HPV self-test is a really great option where available.
And so we have a few minutes left, and I think the final question for today is that we have many advocates on the line who are really great, I think, for advocating for themselves, but also their community and expanding healthcare services and HIV care. And so the last question is, what do you think are some steps that advocates can take away from these presentations to improve HPV vaccination or to implement HPV screening and treatment services within their countries or communities?
I can start. Yeah, I can go ahead and start. So very great question. And I think this is very well poised to kind of think through what the next steps are just for global cervical cancer screening. I think one of the things that we need to really work on is the stigmatization on cervical cancer screening and dispelling myths. I think that what we need is education and awareness about what screening is and why it's important to get screened for cervical cancer. I think that a lot of women have been educated, and there's been some great efforts already in many of the different countries on this effort, but there's still a lot of challenges and barriers to understanding the importance of cervical cancer screening and what it means across countries. And so any ways in which advocacy groups can speak to youth, speak to elders in the community and women of reproductive age and help them to understand what it means, I think is really helpful. Also getting men on board and helping them to understand what cervical cancer screening is particularly important as well. I think that some of the ways in which PEPFAR has helped to do this is really getting for the service delivery platforms where men are being served. We also do educational talks on what cervical cancer screening is, so that when their wife comes to them or their partner comes to them and says, that they need to get screened, oftentimes there's some consent, issues that need to be resolved within the relationship in order for that to happen. And so in areas where that is, an issue, having the men already have education on this beforehand has been really impactful. And also educating on the HPV vaccine and, that it's not just for women, that it's also for men, I think, and young men, I think is also really important as we continue to scale up efforts. I think on the advocacy side, we need to ensure that women's health issues, and particularly cervical cancer, are being included in the discussions for NCD, guidelines and development, and for service integration, really thinking through the full reproductive life of a woman and why it's important to incorporate these elements into their, primary health screenings. And so I think, any ways in which we can speak with the national governments and really continue to keep this issue on the table, I think will be particularly impactful, particularly if we can, help countries to realize why this investment is so needful. So those are a couple of ideas.
And then Helen, I wasn't sure if you wanted to close us out.
Thanks, Alison. I mean, I think Michelle has laid that out so very clearly and comprehensively, and I agree with all of those points. Just a couple of others that I would add is fully behind, increasing awareness and education on cervical cancer screening and treatment for adult women, but also education and awareness among the healthcare workers themselves, because they are the point of contact for many of these women. And it's really important to get these individuals on board also. Screening alone is not sufficient. And I think that in, creating that education and awareness of screening and the importance of screening, I think it's really important to make women aware and healthcare workers aware of the need to follow up those women who screen positive, because screening is not sufficient unless treatment is also administered in those women who are screen positive. So creating that understanding about the pathway or the cascade of screening, triage if needed, and then follow on treatment is extremely important. And I think that message is really important in those education and awareness campaigns. And then finally, I just wanted to mention, we did have a think tank meeting here at WHO on the point of integrating cervical cancer screening in HIV care. And we heard a lot of the experiences from the PEPFAR programs and others, as Michelle has summarized here today. But one of the interesting messages that we heard from the community of advocates and women with lived experience is that while women living with HIV are increasingly having an opportunity to get screened within HIV care, there may be not the same opportunities for women in the general population. And we did hear from that community that they were mobilized to make a change, so that not just the HIV community are availing of these opportunities, but that those services can be made available to all women, irrespective of their HIV status. Yeah, so big steps, but hopefully we can get there. Thank you.
Thank you so much. And this closes out our webinar today. So a big thank you to Michelle and Helen for your presentations for my morning time. They were incredible, and I think we've all taken so much away from them. And I specifically appreciate your advice on what we as advocates can do to really push some of these programs forward. With that, this is the end of our webinar, and you can join us next week as we talk with cervical cancer advocates. And of course, all recordings and slides will be available after this session. So thank you so much and have a great rest of your day.
Thank you. Bye.